I don't know. That's what Andrew. I think that's what Andrew thinks you're going to do. Okay. Well, I'll stand. Good morning, Green Spring. Welcome this Thursday, September 10th day. Next, we are continuing our 10-year celebration of Telly Awards. Stay tuned. Good morning again, Green Spring. I'm your host today, Avon Price, and we have a great show for you today. This is coming back from July 20th of 2006. It is our Bronze Award winner, Telly Award of Depression, that was hosted by Marsha Dake and her special guest. So why don't we sit back, relax, get your orange juice, get your coffee, and let's enjoy this throwback.
Welcome to Village in Motion on this Thursday, July 20th already. 2006. And we have our busy Dr. Lady back. We're always glad when Dr. Gable is here after a busy already morning to go back to one, right? Okay,
yeah, that's
okay.
right.
All right. Well, we've given her 2 seconds to catch her breath. So your topic today is
depression.
Depression, something we all need to listen carefully to.
We've talked about different organ problems, heart trouble, kidney trouble, skeletal problems. When I talked about dementia, I noted the functions of the brain, cognition, sensory reaction, adaptability, control of the body. Mood is one of the functions of the brain.
Mood. Our mood for the day is a function of the brain.
Right, and I want to focus today on depression as a condition of poor functioning of that part of the brain.
Okay.
And I want to talk about it as we know it as a medical disease, to try to broaden people who think that it's a character flaw or a philosophical problem.
Oh my.
I will portray it as doctors view it as a medical problem with a chemical genetic basis.
All right. So when we see a resident, we don't. Oh, why don't they snap out of that? What?
Or a spouse.
Well, or a spouse. Okay. Not having had one of those, I didn't think
That's
of
where
that.
I hear that the most. I don't know why he doesn't just get busy with things and find something that he wants to do that will interest him.
You notice what she said? How? I don't know why he. Something tells me it works with she also. That's what you're going to tell us today.
Right,
okay.
Right.
All right.
Depression has been described all through history. We all know about this. Different terms, melancholia, certainly. In the early part of the 20th century,
Okay.
it was found, we went to theories of what's going on chemically with depression through the back door because some medications appeared that made a difference to the symptoms of depression. And inferences were made by studying what do those chemicals do in the body?
Ah.
It has ended up focusing on a group of chemicals called neurotransmitters.
Neurotransmitters as a medication.
Right.
Part of a
well, as
substance.
chemicals that are normally present in the body, and how these medications that affect the symptoms of depression work on that group of normal chemicals. Neurotransmitters are chemicals that work in moving messages from one nerve cell to another. And I'd like to draw you a picture of that.
All right. This is why we've set up with our. She's going to.
We'll have to see if the cameramen can keep up with this.
I thought you were going to say we're testing your artistic ability.
No, this won't be good art, believe me.
Oh, okay. All right. You can go right ahead.
The nervous system has to direct your foot to move by something that happens in your brain. I told you this was going to be really elaborate.
Yes, yes. Okay.
So for the brain to tell the foot to move, a message is sent to the muscle and move your foot. So it starts with a thought, okay, or a reaction, sometimes not a thought involved. If it's a reaction to stepping on a pin, it starts up here. Now the way that the message moves in the nervous system is by a chemical change, by an electrical change. And it is, there's literally one long nerve cell from the brain to the end of the spinal cord. When this message comes to the end of one of the nerve cells, it doesn't jump across like a spark gap. The electrical message causes a chemical to be given off from the end of one nerve cell and float across the space to the next nerve cell. The space, as you may remember from 9th grade biology, is the synapse. These chemicals that carry the message from the electrical change across the synapse to the next neuron to start off the electrical change again and deliver it to the muscle are called neurotransmitters. Yeah.
Yeah. Neurotransmitters. We've got
neurotransmitters. There are predominantly 3 types of neurotransmitters. Now, in the same message carrying happens in the brain. So, but there are smaller neurons, more neurons to the chain. This is literally 2 neurons, 2 nerve cells, one nucleus per nerve cell from the brain to the bottom of the spinal cord. In the brain, it's chains of smaller ones with very intense networks. And these chemicals carry the message from one nerve cell or neuron to the next. What was found when some medications were found to improve mood was that they boosted the levels of these neurotransmitters. So we came to view, in the middle of the last century, we came to view depression as neurotransmitter deficiency. Mm-hmm. And that has continued. And study has been regarding why does this become low? Is it just one type of neurotransmitter? Are there others? And so forth.
Okay. So we're still talking about those neurotransmitters.
We still are in the 21st century.
Okay.
The symptoms of depression result from changes in how the neurons, the units of the brain carry messages. And of course, some parts of the brain are primarily devoted to mood. So this is where science has gone in my lifetime as a doctor.
Okay, we've had some symptoms of this. You're going to get to that.
Ask me what you want to know.
Well, we were just showing, and what we're talking about is symptoms of medical depression. We're not talking about, well, I don't feel so hot today, I'm a little grumpy. That's not what we're talking about.
Reaction to something sad, for instance, is not medical depression.
Okay.
Grief is not medical depression. Losing at bridge is not, and being bummed out about it is not medical depression. And so far, we are still diagnosing depression by observation of a person's, what's happening
behavior,
with a person, and their answers to questions about how they feel.
You know, you're sending all sorts of thoughts, because it seems to me as if when you say, you know, a depression about death of a spouse, depression about a spouse moving to Renaissance Gardens, that brings it right back home, yes? What I heard you say is that that kind of mood or depression is not necessarily medical depression.
Not necessarily. Now, thinking about what causes depression, let's go back to thinking about diabetes.
All right.
Diabetes is a medical disease. The pancreas doesn't do right, and all the cells of the body don't react right to the use of fuel in the body, glucose. And the things that cause that are, we know, genetics. There may be a family tendency to diabetes. We know that lifestyle affects it, what's going on in the environment, stress, fever, postpartum depression, postmenopause depression, or
menopause depression.
Pregnancy. I bridged over pregnancy diabetes. If a person has a fever, it may run their sugar up if they have a tendency that way, and if people are overweight, it does worse. If they're slim, it does better. So let's think in this way about what causes depression. It's an interaction between a tendency in the body and many things that happen in the environment. But how we diagnose it, just like with diabetes, while we know the sugar varies within a normal range according to what you eat or according to illness, so forth, the way we define diabetes is we have a threshold. If the blood sugar goes above this, then you're diabetic. In diagnosing depression, we have a threshold. If the symptoms go beyond this, that is medical depression, not bereavement or not disappointment. So the things that we look at, and this is very codified. It's not just a doctor guessing at it. It's a list of symptoms, and a person must have, first of all, one of two cardinal symptoms, either depressed mood or loss of interest and loss of ability to enjoy. If they don't have either of those things, we start looking elsewhere as an explanation of symptoms. In older people, interestingly, it's harder to diagnose depression, partly because older people are part of adapting to a lifetime of ups and downs, I think, is older people don't recognize depression symptoms. They're focused more on endpoints and so they're less likely to recognize that something is going on with mood. But also the symptoms tend to be more the loss of interest, loss of ability to enjoy, and fatigue. in depression in all age groups, other cardinal symptoms include, and these usually are present in older people, but as I say, diagnosis follows a little different track. Physical symptoms such as headache, abdominal pain, other pains, the appetite changes, which can be increase or decrease, or just weight loss without an apparent appetite change. Sleep disturbance, which can be more sleep or less sleep. Irritability often is a symptom of depression. Increase in intrusive thinking about death, which can take the form of thinking through past deaths of acquaintances and family, or it can take the form of suicide thoughts, or it can take the form of just focusing on the news and realizing that you can't get that mental picture out of your mind of what's going on in Iraq or what's going on in Darfur.
Oh my.
So intrusive death thoughts. People often have a change in what we call psychomotor function, a tendency to be more restless than is their usual movement pattern, or to be more just inactive than is their usual. In older people, particularly, we hear of difficulty with concentration and difficulty in making decisions. I think that occurs in all ages with depression. I think maybe the reason we hear about that more from older people is because we are sensitized in aging to dementing illnesses.
When we're talking about these last symptoms that you've been identifying, these are symptoms of the chemical, the medical depression?
That's right.
Okay.
The reason I started out with the picture is that we really, as doctors, we really sometimes hit a roadblock in people thinking that this just has something to do with will and character. But if you picture this deficiency and that the brain is trying to work up a plan or is trying to get back to watching sports or planning a presentation at the book club and just can't seem to get that to turn over, if you picture these chemical changes, it makes more sense.
Surely, surely. And this is what we all need to be aware of, and this is the category of behavior, if you will, where our doctors can do really something for us.
The incidence of depression in older people is somewhat lower, surprisingly, than in the younger population, and it ranges somewhere on the order of 6 to 10% of people. Now, door-to-door studies have not been done, so this is people talking to doctors, okay? In nursing homes, the incidence rises as high in some studies as 20% of people, and in hospitalized people, it's up in the 40% in some studies. So obviously, the situation has an effect. Now, in this neurotransmitter thinking, and this is our basis of pharmacologic management. So, and this thinking about it has been around for a good 50 years. So this is. So don't be thinking that this is something you should have read in the Wall Street Journal this morning. It's very basic, just like our basic understandings of diabetes and heart disease. Probably people are born with different amounts of ability to keep up the neurotransmitter level, and environmental things affect that. This is probably where genetics come in. Some people probably are deficient from birth, and we certainly see childhood depression. Some people may have almost unbounded reserves. And when you think about Holocaust stories, you know that in the Jewish Holocaust, some people, as soon as they hit the concentration camp, they hung themselves from in the barracks. And other people made it through seeing their whole families shoveled into the furnaces and went on to build a life afterward. So environment, there is a substrate factor in how environment brings out depression. In treatment, many studies have shown that either medication, pharmacologic treatment, which works in various ways to boost the neurotransmitters, particularly serotonin, the Time Magazine Chemical of the Year of a couple decades ago.
Okay.
Serotonin is the primary deficiency in depression, but the other two main neurotransmitters, dopamine and norepinephrine, are implicated in some cases, and that's still an area of study.
Okay, I want to sort of ask here, because what's going through my mind is when you say the conditions, the disease, if you will, has been known and been around for years, right?
Hundreds, thousands.
Okay. Is our development in pharmacology, in the development of new medications specific to this, is that what is helping to bring it out more than it has been in public areas? You just started to talk about pharmacology.
That's a good question. Why is it that we seem to hear about depression more than we did 60 years ago?
Right.
Well, I've thought about that a lot, and I think that looking back 60, 70 years, everyone knows that there was an aunt who lived kind of a quiet life, just sort of helped the lady of the household. There were the hags and nags of Canterbury Tales, just the irritable character. I think that it's just, as with many things, it's just how we organize our thinking about these things. And now, just using the term depression to refer specifically to a medical condition is just, I really think it's just helping humans sort out what has always been there. And when I started in practice, I certainly can see a huge change. It used to be that when I saw that the diagnosis was depression, I really had to come in the back door on that. I had to work my way around to being able to say to a person, here's what I think is going on, because it was universally rejected as an explanation.
Okay.
And it has come so far around that I have people now come in and say, I think I'm depressed, and it's really that they're in heart failure, or it's really that they're anemic.
Okay. No laughing matter, but it's all right. We laugh on that one.
That's right.
Yes.
It is something for people to not self-diagnose, but to realize that if they have a set of symptoms, they need to describe the symptoms rather than give the diagnosis.
You're answering my questions before I even get them asked, Dr. Gable. Because,
we're good.
Because what I heard you saying just a minute ago was, hey, if we have a sense, if we've got a question of, gee, is this like medical depression? We ought not sit in our apartments and do the wondering. We ought to check ourselves out with our physicians.
Well, at a probable community incidence of between 6 and 10%, it's as likely as diabetes, certainly. And it is, it has an organ basis. And certainly, just like how diabetics may say, I know my sugar's out of control, but I know I need to lose this weight, so what's the point to go to the doctor? That makes no more sense than a person saying, I know I'm depressed, but I know that until my son straightens up and my daughter-in-law is talking to me again and they get all that, I can't get over this. That come to the doctor and use the doctor as a tool. State what's going on, state what you know is affecting it, and say to the doctor, what do you have to offer in a situation like this? Right.
Oh, I think that's marvelous. You've been leading up to that. I mean, there is a point beyond which we as residents, and we're talking to residents now, we're not, well, maybe family, because we could apply these things to our family.
Yeah, that's a point. Yeah.
Really, and they may be affecting us too. but we won't try to belabor that. But the point is that we know. I mean, you've just been describing to us the physical phenomenon.
Yes, that's my point.
To depression. Yes. Want me to say that again?
Thank
I think
you.
I can.
Yes.
What we're talking about is a real, concrete, physical, chemical problem.
Exactly.
Which is basic to the symptoms of depression.
That's it. And anyone that thinks that they're smarter than the doctor, well, they're just being an idiot.
Ooh.
It's a medical
I don't think I'm
problem.
smarter than any doctor, and especially this one. Like I said, she's answering my questions before I get them asked.
They're just, they're not using the tools that are available. It's not that a doctor is going to take over and make judgments on your situation. It's that the doctor can be part of your toolkit on how to manage this. I did want to say, I started to say about the place of pharmaceuticals. Numerous studies have shown that cognitive therapy works as well as pharmaceuticals. The fact is, though, that it is more expensive, takes longer, and that's why we tend to use medications more. The very optimal outcomes have been found with a combination of pharmaceuticals and cognitive therapy. The optimization that we see of management is that the results last longer and people are apt to be able to maintain the normal mood without relapses if they have also had cognitive therapy. And how that affects the chemicals is the same as how if the phone rings in the middle of the night and it scares you, your heart starts beating fast because the adrenaline has been, chemical things happen according to thought patterns.
Okay, you just, oh, I know. You've been talking here like chemical therapy and cognitive therapy. You know, I'm just I don't know what you're talking about when you're talking cognitive therapy.
Things that involve developing thinking patterns, and while I think that the best route to that probably is an experienced therapist who will just be a teacher to you. It's like it's like going to the community college and taking a course in this with that person as the teacher.
Knowledge and behavior discussion.
Right. To what are known to be the best management of thought patterns that will affect those chemicals. But other types of thinking therapy, cognitive therapy, can include self-help books, groups, talking with someone who has experienced something like this to get their perspective on what types of changes in thinking help them. But generally, since that is a more prolonged management, seeing a therapist who usually plans 6 to 8 visits.
Mm-hmm. I'm gonna pick up on that because what's going through my mind is, okay, cognitive, specialists in the field. Okay, that's why we have so many well-trained,
Psychiatrists or psychotherapists?
Well, psychiatrist, boy, I just went and drew a blank. You think psychiatrist, psychiatric specialist, what's Arlene Dawson?
Yeah, social workers.
Social worker.
Yeah, right.
Sure.
And the divisions are psychiatrists, MDs are pretty much confined now to medication management, and that's been a change in the last decades.
Okay.
Psychotherapists, who are usually either specially trained nurses, clinical social workers, or psychologists, right, do the thinking therapy and diagnosis.
Okay.
And then problem solvers who help to sort things out for you can include the social workers and other helpers.
Dr. Gable, I've been watching. You've had some symptoms, and I think we ought to show those again while I'm talking. But
okay. These are the symptoms that are most common in older people, which do differ somewhat from the complete overview of symptoms in depression and how we diagnose depression.
Okay. Well, where I was coming from is, all right, so you've said loss of enjoyment, loss of interest, etc. Those fit me. You know, I'm playing a character now.
Yeah, if it fits a person. Yeah.
It fits me. Do I go to the doctor first, or do I talk with the social worker, or
doctor first?
Doctor first. Okay.
Because you could be anemic, or you could be in heart failure, and just tired.
That's my question.
Loss of the two cardinal symptoms, of which one must be present to diagnose depression. One is depressed mood, just feeling sad, feeling blue. The other, which we see more commonly in older people, is loss of interest and loss of ability to enjoy. So those two things, if either of those are present, either just blue, sad, depressed feeling, or loss of interest, loss of ability to enjoy, that's your starting point.
Okay. I think that, boy, we've really we've been hitting this, haven't we? That's marvelous. How can I thank our Dr. Gable enough for doing her office work, being Superman and flying over to come to Channel 6 and sharing this kind of knowledge? When you see her, professionally or socially in the hall, thank her. Thank her. I'm thanking her today for all of us. Okay?
Thanks, Marcia.
Thanks, Dr. Gable. We're going to now talk about the future like we always do. Today is Thursday. Remember our special...
Well, Wayne and I love to support the Benevolent Care Fund. We've been here 7 years now, and we have participated in this program from the very beginning.
I feel that's really important because it's a way to be involved in the community and at the heart of the community of helping other residents.
I sort of like to share with my neighbors who have greater need than I do, and it's kind of a privilege to be a part of Green Spring that is sharing with our neighbors.
To give something back makes you feel pretty good. Plus, we never know where we're going to go one of these days. It may be that we're going to be a recipient, and I'd hope that other people would do that for me. But we give, and we give heartily. We don't give to get something back. We give because we want to, and we know we're helping somebody along the way.
And one day, it could be me.
It could be me.
It could be me. It could be us.
And we're back, Green Spring. I hope you enjoyed that old feature that we won the Telly Award in 2006 on depression. I hope you truly enjoyed that. Before I let you go on this Thursday day, I have a few announcements for you, okay? So for special programming, we have the Steve Guback Travelogue that comes on today at 2 and 8 p.m. And then we have the Village Church playing at 5 p.m. and 9 p.m. Friday on Village in Motion, hey, you get to see me again. We're going to be continuing our Telly celebration, Poems, Portraits of Black Women from 2007. And then our video time machine is going to be on the Asian Gardens. So you want to make sure you stay tuned for that. That plays on Sunday at 4 p.m. and 7 p.m. That's it that I have for you, Green Spring. Make sure you stay tuned for our feature, Eye on Green Spring. Let's see what it's about today.
Okay. Oh. Hi, I'm Kelly Lukshander, and I'm here with Hazel Poole, and this week we're talking ESL on Eye on Green Spring, the weekly segment where we highlight a different resident group.
We started the ESL group back in 2002. At that time, they were hiring a lot of people pretty fast. And so the council just came up that we had to get some kind of program started so we could help the workers, maintenance people, housekeepers, or whomever who needed help, so they could communicate with the residents, because that was a priority. And a couple years later, we started another class in the afternoon, because the people who come in to work at night, they work different shifts, and we had some from the kitchen, so we had to work around that part of it. And so 13 years later, and our priority is, and still is, to help them with speech, reading, writing. Since then, we have a lot of students working here, then supervisor, they're team leaders, and then the maintenance, they have gotten promoted. Since it's strictly volunteer, the part we look for from the supervisor is to encourage them to come and make it possible for them to come, because it's they get a free, they use part of their lunch hour and they get free time, some free time. One student once told her teacher, and thanked her teacher for teaching her, because now she could take her children to the doctor and understand what he was telling her to do for the children.